Hi everyone, this is Ahmed Line presenting Echo Nerds Notes series from Echocardiography Nerds Facebook group. Today we are talking about coarctation of aorta. Let's start. First of all, we will talk about the morphology and classification of the aortic arch. The aortic arch is divided into three segments. The proximal arch between the innominate or what's called brachiocephalic artery and the left common carotid artery is called proximal transverse aorta. We are talking about the arch of aorta segments. The second part is called the distal transverse aorta, and this is between the left common carotid artery and the left subclavian artery. The third part is called the isthmus. This part is between the left subclavian artery and the ligamentum arteriosum or the ductus arteriosus. So there are three parts of the arch of the aorta: the proximal part, the distal part, and the isthmus. The most common site of coarctation of aorta is the isthmus. It's the last part of the transverse, the last part of the arch of the aorta. Then we will talk about the anatomic criteria for the definition of coarctation of aorta or arch hypoplasia, which are proximal aortic arch. If we are seeing the coarctation in this segment, it should be 60% of the ascending aorta to say that's coarctated or hypoplastic, while if it is at the distal arch, it should measure about 50% of the ascending aorta, while if it is at the isthmus, the narrowing should be at least 40% of the ascending aorta. Another commonly used criteria is the diameter or the Z-score, especially if we are talking about children and neonates. The Z-score depends on the weight and the height of the child or the patient, and we usually say this is hypoplasia, there is hypoplasia or coarctation if the Z-score is less than 2 standard deviation of the normal population mean. So to calculate the Z-score, we should adjust it to the gender and to the weight and height of the patient. There are many types of coarctation of aorta. We may classify it according to its relationship to the ductus arteriosus. So it may be this coarctation may be preductal or may be ductal or called paraductal or postductal. How to assess coarctation of aorta? First of all, we will look at the coarctation by 2D and color. The endoluminal protrusion of the intimal medial ridge or shelf is typically circumferential. We will search about this narrowing, and we talked about the diagnostic criteria for narrowing by measuring it and comparing it to the ascending aorta or comparing it to the Z-score of the patient. We will comment on the size and extension of this coarctation and the type. The type of coarctation may be discrete shelf or diffuse hypoplasia. The length of the stenotic segment usually varies. It may be discrete, or as we called it shelf, it may be discrete, and the length of the narrowed segment may not exceed 2 to 3 millimeter, or it may be a long segment, it may extend from 7 to 20 millimeter. Another note we should take into consideration is that there is high incidence, more than 50% of coarctation of aorta will have associated cardiac anomalies, which suggests that coarctation is more a complex defect than isolated narrowing of the aorta. Coarctation is normally and commonly associated with bicuspid aortic valve, ventricular septal defects, and subvalvular and valvular aortic stenosis. So, if there is coarctation of aorta, we should search for other anomalies like bicuspid aortic valve, like VSD, and like aortic stenosis. Two-dimensional imaging of the coarctation of aorta, we will see this picture of the 2D coarctation. There is, if you notice here, there is a bridge in the posterior wall, because this view is a suprasternal window. In the suprasternal window, there is the ascending aorta, which is anterior, and this is the arch, and this is the descending thoracic aorta. So the descending aorta is posterior, and this shelf is in the posterior wall of the descending thoracic aorta, or as we call at the last part of the arch, which is called the isthmus. It's almost, this shelf is almost located 5 millimeter below the origin of left subclavian artery. This is the left subclavian, and this is the left common carotid. If we, you can notice also there is some sort of post-stenotic dilatation. If you see here, this segment is more distal to the arch, so it's usually and normally must be narrower than the transverse arch and the distal arch, but here it is dilated, and this is common association with coarctation of aorta. It's called post-stenotic dilatation. Then after we assess the coarctation by 2D imaging from suprasternal view or from pedal view, and we will talk about those views on later slides, we should put color mode to assess the turbulence across the defects. Here we can see a coarctation in a small child with a closed ductus arteriosus from the suprasternal sagittal view. We can see there is elongated proximal transverse aortic arch with typical juxtaductal posterior shelf. This is the posterior shelf, and this is the coarctation as we see here. If we put color in this image, there is obvious turbulence seen at the level of the narrowing. So it's very important, because we would miss the coarctation if we don't see this turbulence of flow. Then the third part in our assessment will be application of Doppler modes. And we have two Doppler modes we can apply in coarctation of aorta. The first is continuous wave Doppler, and the second is pulsed wave Doppler. We do continuous wave Doppler in three views: in the high parasternal view, in suprasternal long or suprasternal sagittal view, and in left infraclavicular view, which is called a pedal view. While we use pulsed wave and all these views, we can say that all continuous wave views assess the coarctation from above, from proximal to the coarctation. While if we want to assess the distal flow, distal to the coarctation, we will look from the abdomen, we will look from subcostal sagittal view, and we will use pulsed wave, not continuous wave. We'll use pulsed wave Doppler. So let's start with the continuous wave Doppler. The Doppler wave flow in coarctation of aorta has a very characteristic shape. We see here there is characteristic serrated pattern. It's not pulsatile. The normal aortic flow should be like this, should be pulse, systolic pulsation with no diastolic forward flow. But here we see systolic flow and also diastolic tail or diastolic flow. So it's like acceleration or sawtooth appearance or shark tail sign. It has many names. And we can see here there is a very rapid early acceleration of flow and high systolic flow and also gradual deceleration throughout the diastole. So it is called diastolic tail. We can also appreciate that the cutoff measurement for significant stenosis or coarctation is more than 20 mm Hg as a peak gradient across the coarctation. And here we can compare between the coarctation of aorta Doppler pattern and the normal pulsatile Doppler pattern of the aorta. It's very obvious that in coarctation there is, as we said, there is acceleration, there is increased peak velocity, and there is this characteristic diastolic flow, diastolic forward flow, while in normal flow there is pulsatile flow with almost no diastolic flow, forward flow across the aorta. And so this image shows the difference between the normal flow and the abnormal flow. We'll talk about also the evaluation of severity of coarctation. In evaluation of coarctation severity, it's based, as we said, on peak velocity and peak pressure gradient, not the mean gradient, because inclusion of diastolic phase of antegrade flow would not accurately reflect the systolic gradient. When multiple obstructions are present, usually in the context of associated aortic arch hypoplasia, the corrected coarctation gradient should be measured. If the pre-coarctation velocity is greater than 1 meter per second, and it is calculated as 4 V2 distal aorta minus V square proximal aorta. Again, we'll talk about this correction in later slide, but here we see that we assess the coarctation maximum velocity and maximum gradient, not the mean, as we explained earlier. And this is the continuous wave Doppler through the aortic isthmus demonstrating high velocity systolic amplitude 4.3 meter per second with continuous antegrade flow through the diastole. Another thing we can notice here is that this brighter signal indicates the flow proximal to the obstruction, while this higher velocity signal demonstrate the peak gradient across the obstruction. So this, we can call this pre-coarctation velocity, and this is the maximal coarctation velocity. Why it's important to differentiate between these two signals? Because if this velocity, if this pre-coarctation velocity is accelerated, if it is more than 1 meter per second, we can't use the simplified Bernoulli equation. And this is what I'm talking about. Simplified Bernoulli equation can be used only if this proximal velocity is less than 1 meter per second. We can use P pressure equal 4 V square of maximal velocity. We can directly calculate the peak velocity and the peak gradient across coarctation from this equation. While if we notice that this signal is more than 1 meter per second, we can't use a simplified equation. We must correct this pre-coarctation acceleration, as we said earlier. And in this Doppler pattern, I can explain it simply. This flow characteristic in aortic isthmus in a coarctation, showing a summation of two waves of acceleration of forward flow, which is here. It's around 1 meter per second or less than 1 meter per second, and the accelerated forward flow in systole, which is about 2.5 meter per second, as it is mentioned here. So if we applied simplified Bernoulli equation, it will yield peak pressure, maximum pressure of about 26 millimeter Hg. We can notice another phenomena here, this low velocity diastolic flow. As we mentioned before, that coarctation is characteristic by a high diastolic velocity or diastolic tail. So why there is low velocity diastolic here, low velocity diastolic flow here? And there is also respiratory variation. We see it here and we don't see it here. Why is this pattern? And this against what we mentioned before. This usually occurs with respiratory variation through the aortic isthmus as a result of reduction of diastolic blood pressure gradient because of reduction in the diastolic blood pressure in pulmonary artery. And this occur because of presence of ductus arteriosus. So if there is ductus arteriosus, there will be decreased gradient across the coarctation because of the flow through this ductus from the pulmonary artery. Then we will talk about pulsed wave Doppler application to assess post coarctation or post stenotic flow in descending abdominal aorta. So the view we will use here is subcostal sagittal view, and it will show this pattern of Doppler flow across the abdominal aorta, which exhibits low velocity systolic flow. As we see here, there is slow uprise in the flow with low velocity. It's usually low velocity, does not exceed 1 meter per second. And there is also a continuous flow through the diastole. We can see here a real imaging from a patient with pulsed wave Doppler pattern in abdominal aorta from subxiphoid sagittal view. We can see there is systolic waveform amplitude is low, it's around 0.4 meter per second, and there is also diastolic antegrade flow, as we see here. In normal aorta, as we mentioned before, it's usually pulsatile like this, but in coarctation it's not pulsatile, it is continuous flow. And if we see this pattern in abdominal aorta, we must suspect obstruction proximal to the pulsed wave sample volume. So guys, here what we said, let's recap very quickly. We talked about the parts of the arch of aorta, proximal part, distal part, and the isthmus. The isthmus is the most common affected part in coarctation. We talked about the anatomical diagnosis of coarctation. It should be the diameter of the proximal narrowing more than 60%, or the proximal transverse aorta is less than 60% of the ascending aorta, and this 50% and this 40%. Then we talked about the assessment. We should assess 2D, the site of this coarctation, the size, and the type. Is it discrete shelf or diffuse hypoplasia? We talked also about putting color mode to assess the presence of turbulence. We should also assess the effects of this coarctation, like LVH, like LV function, like presence of collaterals, like presence of patent ductus arteriosus and RV function. We also talked about Doppler application in coarctation by using continuous wave Doppler and pulsed wave Doppler. Continuous wave Doppler is used to assess the maximum velocity and maximum gradient across the defect or across the coarctation from suprasternal views or left parasternal views, which is called the Badal view. We also mentioned that there is characteristic pattern of sawtooth or serration or shark tooth appearance with persistence of diastolic flow. We also talked about when to use simplified Bernoulli equation if the proximal velocity less than 1 meter per second, or using more corrected Bernoulli equation by accounting of this proximal velocity, and we can apply the equation of 4 multiplied by V max, which is this squared minus pre-velocity squared. We also talked about using the maximal pressure and the maximal gradient, not the mean gradient, to assess the hemodynamic significance of coarctation, and the cutoff point is usually more than 20 millimeter mercury. And lastly, we talked about application of pulsed wave Doppler distal to the coarctation from subcostal sagittal view, and we appreciated there is a slow uprise and low amplitude of the wave with continuous flow through diastole and the loss of normal pulsatility. Lastly, there is 4 tips for fellows and for eco-nerds for optimizing image quality in adults. Because obtaining a good image from suprasternal may be a little troublesome, we must adjust patient position. How to adjust patient position to obtain good image quality from suprasternal notch is by extension of the neck. We can use a pillow behind patient neck or between patient scapula. This will enhance the ability to put our probe through the suprasternal notch. Second, we can use a low frequency transducer, because as we know, the lower frequency, the higher the penetration, and we need here higher penetration to delineate the aortic arch and the descending thoracic aorta. We need higher penetration, so we need lower frequency transducer. We can use also harmonic imaging. We can also use left subclavicular window in sagittal plane, which is called Badal view, to visualize the aortic isthmus and the descending thoracic aorta if we can't obtain them from suprasternal view. And thank you, eco-nerds, for this presentation and your attention.